Hi, David.
Hi, Todd. How are you?
I'm doing well. How about yourself?
Not bad. Not bad. No complaints.
I know you're traveling a lot this month, so we should probably jump right into it. I thought normally we don't provide sort of a roadmap of where we're going to go today, but I thought it was important because we're going to go to some really interesting places just to provide kind of a quick overview. So we're going to initially start with the Department of Health and Human Services efforts to lessen the impact of Medicaid redetermination. So starting there, then have a conversation about concurrent dialysis and hospice, and then close with a really interesting case of Braidwood Management versus Becerra. What do you think about that as kind of our journey today?
That is a rich array of topics to discuss.
Okay, well, why don't we get right into it? So help me understand what Medicaid redetermination is.
Well, it's kind of something. This is another impact of kind of trying to unravel the public health emergency that was instituted for COVID during the public health emergency. When we think the spring of 2020, there were a lot of efforts being made to make sure that people had the coverage in healthcare that they needed. That this was not the time to have anybody in gaps. So one of the things that happened at the time was, but they basically gave extended leeway to keeping people on Medicaid um, without without all the financial background work being done, particularly for states that had not expanded their Medicaid coverage under the Affordable Care Act, but just in general for all states. And so that redetermination is going back and looking over all of the information for a particular person or family and determining whether they do indeed hit the Medicaid eligibility level. So that's what redetermination is about in its purest, most simple form. It's like basically saying, are you at the level to be in Medicaid, or are you making too much money?
Okay. So just to be really literal here, it's kind of saying, okay, we're looking at what determines if someone's Medicaid eligible, which varies by state. And during the pandemic, we looked at this in a very sort of flexible way, trying to be as inclusive as possible. Now that the government has determined we're on the other side of the pandemic, we're redetermining sort of eligibility for Medicaid, which by sort of implication means we'll constrict the number or reduce the number of people participating in the program. Is that kind of a general overview?
That's exactly right.
So what do you, I guess a question I would have is I don't want to get down the debt ceiling, but just in terms of the agreement that was just reached between the president and Congress around kind of trying to really freeze a lot of spending, does that play into this as well?
Not quite as much, because this is really also happening at the state level. So there's a lot of what states determined to do. And I think overall, our members have been very concerned that if this happened too rapidly, and if some states were too eager to get this done in a big hurry, that people would end up being dropped for really administrative reasons. Excuse me. Our members were concerned that people might be dropped for administrative reasons if this moved too rapidly in some states. And that's something that the Department of Health and Human Services are clearly concerned about. The action that they've taken this week basically says we're very concerned about how rapidly this might be moving in some situations, and that's a concern because I mean the estimates go very high that we could end up with as much as 15 to 17 million people actually being unenrolled from Medicaid at this particular time or in the months ahead. And they're really concerned that that could be too rapid, too many. And they've provided flexibilities and they want the states to be willing to take advantage of them. So they had made this clear back in March, but they really wanted to come back and say again, look, we want to remind you, we've given you some flexibilities. Please use them and take the time to make sure that you're not unenrolling people and children in particular who really should be able to who really should be able to continue having coverage.
So I guess before we move to our next issue, I mean, part of the issue here too is, or I know that the HHS Secretary Javier Becerra sent a letter to the governors expressing sort of what you've just described. What's sort of the next step in this discussion?
Well, I think the next step is for HHS to basically be as helpful as it can and supportive as it can, and I think also for individuals who are concerned about this, like our members and our listeners, to express that to their state government, to their Medicaid program office. That basically they want them to take the time to do this correctly. They've given some eligibility, leeways and flexibilities for things like if you're already enrolled and eligible for SNAP, Supplemental Nutrition Assistance Program, or temporary assistance for needy families, TANF. If any of those are the case, you could use that as a kind of a way to redetermine someone is still eligible. So there are different ways in which you can do that. There are pauses that states can take before unenrolling somebody, and so that's just, I think, what HHS is going to try to continue to do in the months ahead is really encourage states not to move too quickly and to basically take care of to basically be mindful of all the options and flexibilities they have.
So I think this also provides, in addition to a nice transition to our next issue, is just really thinking about the fact that increasingly, I think as an organization, ASN will probably be addressing issues around Medicaid policy and really the Medicaid program. And part of this is a result of so much healthcare being delivered at a state level and sort of understanding those issues, but also just the fact that there is this tension that's playing out across the country in terms of the individual states versus the federal government, but also then as a result of the Affordable Care Act and sort of thinking of the second, third, fourth tier of implementation of that law and what that means in terms of the relationship between the federal government and state governments.
Exactly. There is a lot of areas there that I think there's going to need to be better coordination in order to kind of really deal with the continuity of care and basically making sure that the people that our members take care of really do have access to all the programs that they need.
No, the second issue is concurrent dialysis and hospice, and it's interesting because now we're going from a broad topic with Medicaid redetermination to a very specific sort of nephrology related topic. And what's the issue here?
Well, the issue here is exactly what we've just been talking about. Are the patients of ASN members really being able to maximize all the programs that really are there for you? And hospice is one that most all of us will face at some point, someone in our family, and I did last year myself. And so placing someone in hospice and making sure that their care is really palliative, is really kind of really does address the needs that they're having, particularly at the end of life. And so when you look at that, the use of hospice in the population that has kidney failure, ESRD population, is much lower than what it is among regular Medicare beneficiaries. And the reason is such that there's been a lot of confusion about whether or not you can have concurrent dialysis while also being on hospice. And there have been some areas in which basically, it gets interpreted by Medicare that it's a life extending modality, so therefore you shouldn't be able to have it within hospice. And what we all know is that happens quite often is that most hospice companies that are providing you the care and signing you up really will not sign you up until you declare that you are no longer doing dialysis. And since your care is now all being paid for through that program primarily, what's being paid to them for other services just really does not allow them to cover dialysis at the same time.
So I'm trying to kind of understand the policy implication. What are the policy levers here? I guess maybe that's the question.
Well, I mean, when you think about it, there's a whole lot of structure that's really very important in the ESRD benefit within Medicare. which is designed to make sure that people who need dialysis are receiving the type of dialysis they should. And the government wants to make sure that that the concern over just exactly how much dialysis is needed, how often it's needed, and to what level of clearance that you're conducting and taking care of that patient is really important to the safeguards and safety rails for patients. So when you talk about hospice care, a lot of times you're talking about your dialysis might become something very different. It might not fit the requirements of the quality incentive program, which governs all the quality metrics within dialysis care. And so you might be dialyzing less frequently. You're dialyzing for relief and for palliative reasons, but you're not dialyzing to do exactly what we do on a regular basis. Let's say if you're going 3 times a week to in-center hemodialysis, you don't necessarily need to have that same level of clearance in the dialysis process. And so therefore, there's a lot of concern that the way the program is structured with hospice, you really don't have the option to be able to continue that, not as life-sustaining, but as basically more palliative and more quality of life as you go through the hospice process.
So as we kind of shift gears to process here, I know that the Centers for Medicare and Medicaid Services had a request for information, I believe, last month, or at least ASN responded last month. Can you just talk a little bit about that response and then sort of where this issue you think is headed?
Sure. Like all the other programs, there's an annual renewal of the program, and it's a proposed rule that comes out, and it basically kind of lays out things that they're going to try to do to make changes for the coming year. So in this case, the proposed rule for 2024 for the requirements for hospice programs and hospice conditions of participation had in it a request for information, an RFI, and it asked a series of questions, which really all have to do with the issues that we're discussing here and whether people do have access to dialysis concurrently with hospice and whether they should and how it should be structured. And it basically does all of the things that we think about in this case. So when you look at the letter that is linked on the ASN website about this, we kind of lay out the reasons why and what the evidence says that it really would be important for the government to make sure that it's very clear. And what we did is we did ask the government to make sure that there was broader coverage for concurrent hospice and dialysis, including transportation, which our members say constantly is one of the biggest challenges for patients. Being able to dialyze in a center, if you want to be in a center with palliative approaches to dialysis care, which means that you might need not necessarily being dialyzed to the prescriptive level that under the QIP we would normally expect to see. And so therefore you would not be penalized. The facility would not be penalized for dialyzing you in a different way, a customized dialysis with hospitals. And then also to allow upstream models of care to include palliative care to kind of help with the symptoms and goals of care for patients who are still receiving some amount of maintenance dialysis, to kind of really promote a smoother transition into hospice care and end of life services.
And you mentioned, excuse me, and you mentioned the QIP. So just really quickly, could you talk a little bit about the quality incentive payment program?
Yeah, that's part of there are two main sections of the ESRD benefit. One is the prospective payment system, and that's how they calculate all the various things that go into payment for dialysis, primarily to the facilities. And then there's the QIP, which also governs the quality and really has where the safety guardrails are for patients. And so we're not objecting to the QIP. We're just saying that the QIP might not make sense to be fully enforced in this situation because you need to provide the ability for the patients to have customized dialysis that, like we said, might be less frequent and also might be less intense, and that would be really useful for a patient who is going through end of life.
And I guess just before we move to the last issue, you'd mentioned incentives for or making sure that there's an opportunity sort of upstream in terms of palliative hospice and hospice care. Uh, And you had mentioned sort of going upstream in terms of incentives for hospice care. Something I think we as a community have done a poor job of, and ASN has not articulated as well as possible. And I do think it's a good topic for a future discussion. Is kind of this continuum as we think about all these different levers and all these different activities and how starting with U.S. Preventative Services Task Force and the importance of identifying people as early as possible at risk for kidney diseases, then aligning the system in such a way where the healthcare system is thinking about and is incentivized for not only identifying people early, but slowing their progression, ultimately controlling their progression so they don't advance to kidney failure. But if they do, then having as many opportunities, particularly for home dialysis, but the sort of patient choice opportunity, dialysis modality, and also simultaneously making sure that we've done everything possible to align incentives to increase transplantation, have that happen as early as possible, and then moving also to this last piece, which again we don't talk as much about, around people their lives and what can we do to ensure the highest quality care then too. I mean, to me, that's kind of the sort of big picture overview. And then we have all these different policy levers across it that we're working, some mostly in the regulatory arena, but then a lot of legislative ones who done specifically on transplant, the Living Donor Protection Act. So we can have more living donors, hopefully more organs available, hopefully more people then being transplanted. So I leave anything out on that very quick summary because I think maybe we need to step back and kind of start there and then help people understand where each of these different policy levers fit within that world.
Yeah, and I think that's one of the big conversations that's been going on, in Washington and outside of Washington and around states, and probably more actively around states, probably even than in Washington, about how we really deal with those transitions, how we deal with comprehensive care, and really making sure that it is, as you said, we've got a big drive for population health in the country, and that's a good thing. But there are going to be times when you need to be able to take care of a patient in a customized fashion. And so how do you balance population health goals with the goals and the preferences of a particular individual, which nephrologists have to deal with that one constantly.
Yeah, and that provides a really nice segue into our third issue, Braidwood Management versus Becerra. So again, Becerra is the secretary of HHS. So when people are suing sort of the federal government on health issues, it's usually HHS, and it's usually directed at the secretary. So it's a preventative services issue. So what's the topic here?
Well, to be honest with you, they basically in the case, the plaintiffs basically say, and that would include Braidwood, that their religious rights are being interfered with by the Affordable Care Act. So basically, the plaintiffs are objecting to some of the preventive services, in this case, the provision of HIV prevention drugs under the Affordable Care Act.
Yeah, and it's interesting too, because this is another situation where it was the U.S. Court of Appeals for the Fifth Circuit. There's been a lot of we've talked a lot about decisions sort of in opposition to the Affordable Care Act or to other activities, particularly around reproductive health, that have come out of this circuit. And just so people know, the three states that are involved, this is the courts that cover Louisiana, Mississippi, and Texas. And so there's clearly, as I've thought a lot about this, if you think in concentric circles, there's the federal government, there are now these kind of courts that are multiple states, and then there's the specific states, and there's kind of a three-dimensional chess game going on here across them. And then the nephrologist and the nephrologist's patient population are in the middle of this, that then ASN as an organization and other members of the kidney community are trying to navigate. So where is this case headed, and why do you think it's so important for our listeners to understand it?
Well, I think the basic reason why it's so important is it started with a federal judge in Texas basically ruling with the plaintiffs and basically saying that the United States Preventative Services Task Force, which we talk about a lot in terms of recommendations for preventative care, doesn't have the authority to recommend some of the things that it has recommended, or that the government in general doesn't have the authority to do it. So this judge sided with them, and effectively tried to nullify the preventative care requirements of the Affordable Care Act. And that's where I think our listeners would be very, very, very concerned. And that's why it's something that can be very narrowly defined becomes very important, because it could undermine a big portion of the Affordable Care Act. So that led to an immediate appeal by the government to the Fifth Circuit. And as you said, that's the circuit that oversees the state of Texas's judges. The circuit case was probably a good opportunity for that to be overturned, for that ruling to be overturned. Now, what's happened is the plaintiffs and the government have reached an agreement, an order that stipulates certain things that both sides have agreed to, and the Fifth Circuit has accepted. And the reason why this is really important is because if you succeeded at the Fifth Circuit of overturning this case, overturning the ruling from Texas, there's a good chance that this goes straight to the Supreme Court. And I think everyone realizes that may not be where they want to take this case at the moment in the government, that they may not want to have this being looked at by the Supreme Court right now. And so in so doing, they basically said, okay, we're going to make an agreement. We're going to make an agreement with these plaintiffs that they will not have to pay for this during the appeal process. They will not have to pay for this certain type of care. And there won't be any penalties in case the plaintiffs lose. There won't be any penalties that will be leveraged against them at the end of the process. However, other care programs, other care providers will have to be able to cover these things. And so therefore the order does not go into effect across the country, as there was the potential of it doing. So that is kind of the big agreement that has been reached and was signed. And so there's a little bit of a breathing room space here now to kind of everyone to kind of figure out where they're going to go next. And you got to understand that the plaintiffs in this case and Braidwood is a very small company. They are talking about very small numbers of people. So the government was willing to say, okay, you can sit this out and not provide this while we're going through the appeal process, and we will not penalize you. But we do not want this ruling that came out of Texas to be implemented and enforced nationwide. And the Fifth Circuit said, okay, we'll let that happen and everyone can proceed with their appeals process.
So do you think part of what's happening here is that through the judicial system, individuals who are opposed to the Affordable Care Act are kind of forcing the Biden administration and presumably congressional Democrats to kind of to the negotiating table?
Somewhat, but this is part of our judicial system. This is not an uncommon thing. And then in this case, I think they're also, as much as anything, they're expressing their religious views of support or not support. And that involves the Affordable Care Act at this moment, but it can involve other types of programs and statutes. But that's really that's happened. That's a big part of the history of the judicial process in the United States. So it just kind of goes with the system that we have.
Yeah, no, that's well said. I'll give you the last word, but I'm struck that these three topics are so, in some ways, they're very dissimilar, but there is a through line with them in terms of Medicaid redetermination, concurrent dialysis and hospice, and then Braidwood Management versus Becerra. So, David, you have the last word.
Well, as many of our leaders have always said, the devil's in the details. So when you're in policy, you've got to look at every detail because it has implications in all kinds of ways that you might not have thought of.
Oh, great. Thank you very much.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.